So actually, Yuko is going to do this, so I'm using most of her slides. We do have a new CPT code as of January 1st this year, and for ultrasound, the CPT code is 76978, ultrasound, targeted microbubbles, contrast characterization, non-cardiac initial lesion with an RVU of 1.62. And the contrast agent and the organ are agnostic, meaning the code can be used for any of the 3 FDA-approved agents, and you can use it at any abdominal organ. You can also bill for the non-contrast exam with the existing CPT codes. And you are also allowed to bill for subsequent injections if you're evaluating an additional lesion. So you can't bill for another injection if you're looking at the same lesion. It has to be a separate lesion or a separate organ, and you can use 76979, and the RVU for that is 0.8. So I think that's going to significantly increase the number of people who are going to be doing ultrasound contrast, because those of us that have been doing it for 20 years for nothing will all now get paid. So, and I'm sure a lot of institutions would not do this when they wouldn't get reimbursed. In terms of guidelines, there's the WFM and FSM guidelines. The 2 are listed here. We're having an updated WFM guideline this summer, so I suspect that it'll be published near the end of the year. The ACR, AIUM, SRU practice parameters for ultrasound contrast are just about finished, so those will be out shortly. ACR appropriateness criteria are being reviewed, and hopefully ultrasound contrast will be added to some of those. And the SRU is writing recommendations for ultrasound contrast in North America, and again, we hope to have those out by the end of the year. So again, here's the appropriateness committee. There are several areas where we would like to have ultrasound contrast put in, including liver and renal, as several others. Again, these are in works and take some time to get done, and then you get a score. The higher the number, the more evidence there is that it works. So in other words, you would want to order the highest number test when you're ordering this. When we looked at practice guidelines for hepatocellular carcinoma diagnosis, these are the agencies, and you can see there are 2 agencies, ours in the United States, the American Association for the Study of Liver Disease, which still is not recognizing CEUS, and EASL, which is the European Association for the Study of Liver Disease, not yet including these in their guidelines. As of last year. EASL is now in 2018 adding CEUS. So right now, the only liver association in terms of diagnosing HCC that's not has CEUS in their guidelines is the American Association for the Study of Liver Disease. This is their guidelines from 2011, and as you can see, that they recommend for lesions greater than 1 centimeter or more, again, CT and MR, and not use ultrasound contrast. Lesions less than 1 centimeter, just get repeat examinations until the lesion enlarges to greater than 1 centimeter. So I think there's some effort by Yuko and others that at least we go to them and say, if you can't get an enhanced CT or an enhanced MR for the evaluation, you should allow the patient to get a CEUS in those cases. And again, the reason they don't want to endorse this is they are not as well educated about this. Many of them, people on the committee, do not believe in the efficacy of ECUS. So a lot of this is show me the data, that we need more results. And we don't have many large trials in the United States, which is part of the problem. And I think that Andrej and others are doing some studies to hopefully get the information we need to get these organizations to insert ultrasound contrast in their guidelines. If we look at the literature, and again, most of this is not from the U.S., it's from elsewhere. Friedrich Rust did a large meta-analysis of 45 studies with over 8,000 focal liver lesions, and ultrasound contrast had a sensitivity of 93% and a specificity of 90%. 7 studies compared compared it to CT and MR. And again, there was no difference in specificity between CEUS and CT and MR with contrast, but the sensitivity actually was higher than CT and MR. This is just the data from the different sites, and you can see the majority of sites get pretty reproducible data that's quite good. And when we look at HCCs, the pool from 13-year meta-analysis, the pooled per lesion sensitivity and positive predictive value of CEUS, again for HCC, was 84.4% to 89.3%, which was higher than that of CT and MR. So there is a lot of literature that actually shows that CEUS is very competitive with CT and MR and may be better than those other modalities. Again, I think the big problem is we haven't had any studies in the U.S., which has been the problem. I summarized some of these, and these are actually my slides that I show that there are 3 studies that directly compare CEUS to enhanced CT. The first study by Quay, they only took problems that couldn't be solved on CT and did CEUS. And what you can see is in those 89% of those, they were able to diagnose. So I think Stephanie has been another proponent. When CT and MR can't answer a question, doing CEUS can often answer that question. The other 2 studies, again, showed superiority in both sensitivity and specificity of contrast-enhanced ultrasound over contrast-enhanced CT. If we look at the studies that have directly compared CEUS and MRI that's enhanced, we have 3 studies. In 2 of the studies, the sensitivity and specificities were higher with CEUS, and in the 3rd study, they were basically equivalent. Andrej went over the BI-RADS and the probability of HCC, and now that we have CEUS LI-RADS, people are doing studies to see if we are meeting the goal of LR5s having a near 100% sensitivity and specificity for HCC. And here are 2 studies that show 96% and 98.5%. And again, as has been brought out by Andrej and Stephanie, that the LRM contains about 50% HCCs, but the characteristics were not that we can make a diagnosis with high enough specificity to not do a biopsy, and that a significant number of HCCs also occur in LI-RADS 4. And again, in these studies, 86 and 91%. And if we look at LR3, where we would hope there would not be a lot of HCCs, we do fall within the probability with the one study of 47%. And again, Andrej and several others in the U.S. and in Italy are doing a study that hopefully will answer some of these questions, and they'll provide the data we need to get these into our guidelines. So take-home messages, we now have a CPT code. We have been billing. It's a little bit early now for us to know what reimbursement we're going to get. I mean, we have our RVUs. Just because we have the code doesn't mean every insurance company is going to cover it or pay it based on the RVUs that are assigned. So I think we need a little bit more time for us to know exactly the reimbursement. We know that CEUS saves money and is very cost effective. It saves time and gives us quicker diagnosis and other benefits, of course, that we've talked about all day today. And again, the ACR appropriateness criteria is very important for insurance coverage, and we expect some updates in that next year. And hopefully, we're really pushing to get CEUS a high number in that so that it would be a recommended examination for a lot of liver and renal evaluations. And again, these other organizations, I think, are going to wait until we have some more studies in the U.S., so hopefully those of you that are interested should be involved in these studies so we get the data to get these put into the guidelines so that they are more widely accepted. Questions?
Hey, Richard, I'll